Hello friends, I am Dr. Vaibhav. Today I'll be discussing ophthalmology part of grand test number 181. So let's begin with question number 29 first. The question is, the given image is a feature of, the first option they have given is blunt trauma, posterior uveitis, anterior uveitis, and D is intermediate uveitis. So the correct answer of this question is option number C, anterior uveitis. So to solve this question, what all you need to know is about the anatomical classification of uveitis, because they have given all the three types of uveitis, and you should know the image they have given, what is festooned pupil. So the given image is of festooned pupil. This is an irregularly dilated pupil. So let's begin with uveitis. So we should know about the anatomical classification of uveitis. Anatomical classification of uveitis. According to anatomy, they are divided into three broad categories. First is anterior uveitis. First is anterior uveitis. Second is intermediate uveitis. And the third is posterior uveitis. Now what is uveitis? You should know. So it contains itis, means inflammation of the uveal tract. A part or whole of the uveal tract involves uveitis. What is anterior uveitis? It involves inflammation of iris and pars pliccata. So anterior uveitis involves inflammation of iris and pars pliccata of the ciliary body. So as you all know that ciliary body has two parts, pars pliccata and pars plana. Pars pliccata lies anteriorly and pars plana lies posteriorly. So in anterior uveitis there is inflammation of iris and pars pliccata. It is also known as iridocyclitis. It is commonly known as iridocyclitis, and just remember that this anterior uveitis is the most common form of uveitis. So this is the most common form of uveitis. Now coming to intermediate uveitis. Intermediate uveitis involves inflammation of pars plana. So it involves inflammation of pars plana. And peripheral retina. Peripheral part of retina is involved, right? So in intermediate uveitis there is inflammation of pars plana, peripheral retina and vitreous, right? In anterior uveitis the primary site of inflammation, you should know is aqueous. The primary site of inflammation is aqueous, whereas in intermediate uveitis the primary site of inflammation is vitreous, right? Now coming to posterior uveitis. Posterior uveitis is also known as chorioretinitis. It is also known as chorioretinitis. So as the name suggests itself, it involves inflammation of choroid or retina. And the primary site of inflammation is again retina or choroid. Right? Another term you should keep in mind is What is pan-uveitis? So you can come across this word also, pan-uveitis. What is it? It involves inflammation of all the three structures of uvea: iris, ciliary body and choroid. Right? So this is pan-uveitis. So this is all about the anatomical classification of uveitis. Now come to clinical features. So what all are the symptoms of anterior uveitis? The patient will come to you in your OPD with chief complaints of, patient will present to you with dull aching pain. Patient will have pain. This pain is referred across the branches of the trigeminal nerve to your forehead and scalp region, and the pain is more worse at night. Other symptoms, patient will also complain of lacrimation, redness. Patient will have redness, lacrimation and photophobia. Patient will have photophobia along with blurring of vision. Now important thing is that why there is blurring of vision in anterior uveitis. So blurring of vision can be due to, aqueous turbidity. There will be aqueous turbidity, means there will be presence of aqueous cells and presence of aqueous flare. Right? It can be due to cornea will be hazy. So there is hazy cornea because of actions of the toxins or raised intraocular pressure, and blurring of vision will be due to induced myopia. Now why there is induced myopia? Because of ciliary spasm. Because of ciliary spasm, patient will have induced myopia, which will induce blurring of vision in the patient. Right? So these are the symptoms. Now comes to sign. So the patient is examined on the slit lamp biomicroscopy is used for the examination of the patient. And what are the signs? You see. Now let's see the question. In this image, you can appreciate there is adhesions of the pupillary margin with the anterior lens capsule, right? So there is adhesions of the pupillary margin with the anterior lens capsule. This condition is known as posterior synechia. This condition is posterior synechia, and in this image these are localized posterior synechia. How they look like? These are posterior synechia, right? Localized posterior synechia, and this type of pupil on dilatation is known as festooned pupil. This pupil is known as festooned pupil. This is irregularly dilated pupil. This is irregularly dilated pupil is known as festooned pupil, right? What are the other signs you will see? Patient can have, you will see circumcorneal congestion, circumcorneal or ciliary congestion, right? Circumcorneal or ciliary congestion you will see. In the cornea, what you will see? In the cornea, you will see corneal edema, hazy cornea, due to raised intraocular pressure or due to actions of toxins. Then there will be presence of keratic precipitates, also known as KPs, right? So KPs are nothing but these are accumulation of the inflammatory cells on the back of the cornea. So KPs are present on the back of the cornea. Back of the cornea means on the endothelium. So KPs are located on the inferior part, inferior triangular-like fashion they are present. This triangular-like fashion is known as Al's triangle. This is known as Al's triangle, with apex of the triangle pointing upwards due to action of the gravity and the aqueous flow, right? So there will be presence of KPs. Then in the anterior chamber you will see aqueous cells and aqueous flare. Now what are aqueous cells? Aqueous cells are made up of mainly neutrophils. They are mainly made up of neutrophils, and their presence, the presence of aqueous cells indicates the presence of inflammation. So these are indicators of inflammation. They are indicators of inflammation. The presence indicates inflammation, and the number of aqueous cells indicates the severity of inflammation. They are mainly composed of neutrophils. What are aqueous flare? Now you see aqueous flare because of leakage of aqueous protein, leakage of proteins. So there is leakage of proteins. Which protein do you see? Mainly of albumin protein is seen in aqueous. From where these proteins are leaking? From the leaking iris capillaries. From leaking iris capillaries, these albumin proteins leak into the aqueous, right? Now coming to posterior synechia, we have already discussed. This is the attachment or the adhesions of the pupillary margin with the anterior lens capsule, and if you try to dilate this kind of pupil, you will get a festooned, irregularly dilated pupil, right? Now there is another condition that you should keep in mind, that is seclusio pupillae. Seclusio pupillae. What is that? Now if the posterior synechia, means the adhesion of the pupillary margin with the anterior lens capsule, is present 360 degree, if it is present all around the pupillary margin 360 degree, the condition is known as seclusio pupillae. Means what happens in seclusio pupillae, the aqueous cannot flow from posterior chamber to the anterior chamber. So as you all know that normally what happens, that the aqueous flows from the posterior chamber to the anterior chamber via pupil, right? But in this seclusio pupillae, because of the 360 degree posterior synechia, there is no flow of aqueous from the posterior chamber to anterior chamber, right? So what will happen? Pressure will build up in the posterior chamber and the aqueous will push the iris forward, and the condition is known as iris bombi. There will be iris bombi in which AC will become shallow. In iris bombi, AC will become shallow, and this condition further can lead to secondary angle closure glaucoma, right? So you should also keep in mind about the seclusio pupillae. So these are all you should know about uveitis. Correct option is option number C, anterior uveitis. Festooned pupil is a clinical feature of anterior uveitis. One thing you should also keep in mind about uveitis is complications. What will be the complications of uveitis? The most common complication that you should keep in mind is complicated cataract. Complicated cataract, right? This is the most common complication of anterior uveitis in pediatric age group patients. In pediatric age group, complicated cataract is the most common complication of anterior uveitis in pediatric age group patients. Second complication, what you will see is cystoid macular edema. You can see cystoid macular edema also, which is the most common cause of loss of vision if posterior segment is involved. If posterior segment is also involved in anterior uveitis, right? CME, cystoid macular edema. And eye can also go into phthisis bulbi. This is the end stage. What is phthisis bulbi? This is soft and shrunken eyeball. This is soft and shrunken eyeball, phthisis bulbi. And the last complication that you should know is important is, this is one is important, band shaped keratopathy. Patient can develop band shaped keratopathy. What is band shaped keratopathy? This is what happens. Calcium ion deposition occurs in Bowman's layer of cornea. Yes, it occurs in Bowman's layer of cornea. There is calcium ion deposition occurring. So this is all about uveitis that you should keep in mind while solving this question. Now coming to next question, question number 30. So question number 30 says true about various stages of cataract. So first statement is fourth Purkinje image is not seen in immature cataract. Yes, this is true. Second B option, iris shadow not seen in mature cataract. Again, this is true statement. And statement number 3 is deep anterior chamber in hypermature cataract. So correct answer is option number D, all of the above, as all the 3 statements are true. So let's discuss one by one. Question number 30. So option number A, they are talking about Purkinje images, right? What are Purkinje images? What are Purkinje images? So when you throw a beam of light in the eye, there is refraction of light taking place at various interfaces, and you will see Purkinje images. So there are total 4 Purkinje images at different refracting surfaces. The first Purkinje image is seen at anterior corneal surface. The second Purkinje image is seen at posterior corneal surface. Third is seen at anterior surface of lens. And the fourth is at the posterior surface of lens. So there are total 4 Purkinje images seen, right? So they have given in this question, they are asking about the immature senile cataract. So because of the opacity in the media, in the lens, So suppose this is cornea and this is our lens, right? So first image is seen at the anterior corneal surface, second is seen at the posterior surface of the cornea, the third is formed at the anterior lens surface, and the fourth image is seen at the posterior lens surface. In immature senile cataract, because there is cataract, the media is hazy, you cannot see fourth image, right? Whereas in aphakia, there will be how many images you will see? First and second, because lens is absent in aphakia, so third and fourth image will be absent, right? So this is about Purkinje images. Second option they are talking about is iris shadow is not seen in mature cataract. This statement is also true. So what happens is that in immature senile cataract, it is a grey colored opacity. Immature senile cataract is a grey colored opacity, and there is presence of clear lens substance. There is presence of clear lens substance between the pupillary margin and the cataract. So when you are doing a torchlight examination, you will see iris shadow in immature senile cataract. So there is presence of clear lens substance in between pupillary margin and cataract, right? So on torchlight examination, you will see iris shadow. Iris shadow is seen, right? But in mature senile cataract, when this immature senile cataract matures further, it will lead to mature senile cataract. What happens in mature senile cataract? It is a pearly white color opacity. It is a pearly white opacity. What happens? That there is complete opacification of the cortex. In mature senile cataract, there is complete opacification of cortex occurs, right? Now because there is completely opacified cortex, there is the pupillary margin lies in direct contact with the cataract. Pupillary margin is in contact with the cataract. So on torchlight examination, there is no iris shadow. There is no iris shadow, right? So now coming to next option. Next option, option number C, they are saying that deep anterior chamber in hypermature cataract is seen. Yes, this is also a true statement. Let's discuss how. So what happens in hypermature senile cataract? In hypermature cataract, there is disintegration of the cortical matters occurs. Because of this disintegration of the cortical matters, the cortex, the degenerated cortex, it leaks out of the lens capsule into the aqueous humor, due to which the AC becomes deep and the anterior posterior length of the lens will decrease. So in hypermature senile cataract, cortex becomes disintegrated. Cortex becomes disintegrated and the degenerated cortex, it leaks out. It leaks out from lens capsule, right? So when it leaks out from the lens capsule, AC becomes deep and the anterior-posterior diameter of lens will decrease, right? Now what will happen further? Further in hypermature cataract, the capsule, the anterior capsule will get thick, it will thicken. Anterior capsule thickened. Why it is thickening? Thickening occurring at anterior capsule because of calcification. Anterior capsule is thickened because of calcification, which will further lead to the lens and the iris will become tremulous, right? Tremulousness of the lens and iris is seen. The condition is known as phacodonesis and iridodonesis. This condition is known as phacodonesis and iridodonesis, which can cause this hypermature senile cataract, can cause subluxation of lens. Subluxation of lens can occur in hypermature senile cataract. This is the most common complication. This is the most common complication of hypermature senile cataract, right? So this is all about you should know in this question. Coming to next question. Question number 31. The following is true about adult chlamydial conjunctivitis except here option number A, they are saying it is caused by D2K serotypes. Yes, this is a true statement. Option B, transmission by autoinoculation. Yes, this is also true. Option C, superior conjunctiva is commonly involved. This is false. And option D, essential to identify and treat sexual partner. This is also a true statement. So the correct option is, question number 31 is C. Superior conjunctiva commonly involved. This is a false statement. So let us discuss briefly about chlamydial conjunctivitis. Chlamydial conjunctivitis, question number 31. Chlamydial conjunctivitis. So you should keep in mind that the other name of this is swimming pool conjunctivitis. Swimming pool. It is also known as swimming pool conjunctivitis. Right? So what happens in this? It is an acute or chronic follicular conjunctivitis. So it is a follicular conjunctivitis with mucopurulent discharge. With mucopurulent discharge, right? Now what is the causative agent? Causative agent you should keep in mind. Chlamydia trachomatis. It exists in various serotypes. The A, B, and C serotype, they can cause trachoma, whereas the D2K serotypes, they can cause chlamydia, they can cause chlamydial conjunctivitis, right? And they can also cause other disease. They can cause is ophthalmia neonatorum, right? So in chlamydia trachomatis, chlamydia conjunctivitis is caused by D2K serotypes. Now coming to the transmission of the disease, how the disease is transmitted. So you have to keep in mind that the 90% of the transmission occurs by auto-inoculation. Auto-inoculation from the genitals. 90% of the transmission occurs by auto-inoculation from genitals, and the 10% transmission occurs, the eye-to-eye spread of the infection occurs by contaminated water in swimming pools, right? So this is the reason we call it as swimming pool conjunctivitis, right? Now after discussing the transmission, let's come to clinical features. The special clinical features in chlamydial conjunctivitis is it has a benign course. It has a benign and a self-limited course, right? And there is presence of follicles. There is presence of follicles which are maximally concentrated in the lower fornix, not in upper fornix. They are maximum concentration is in lower fornix. Along with follicles, there will be pre-auricular lymphadenopathy. There will be pre-auricular lymphadenopathy is also seen. So this is about the clinical features. Now coming to diagnosis, how you will make the diagnosis. Diagnosis can be made by direct immunofluorescence, or McCoy cell culture. This can be used. McCoy cell culture can also be used, and GIMSI staining is done. On GIMSI staining, what you see is, you will see intracytoplasmic inclusion bodies. So intracytoplasmic inclusion bodies are seen, and these bodies are called as HP bodies, right? On GIMSI staining, you will find intracytoplasmic inclusion bodies known as HP bodies. Now, after making the diagnosis, what is the treatment options we have? So first option is that we give 1 gram of oral single dose of azithromycin. One gram oral single dose of azithromycin is given not only to the patient but also to the sexual partner. Why? Because the disease has transmission. 90% of the transmission is by auto-inoculation from the genitals. Second option is you can also give doxycycline. So doxycycline 100 milligram BD for 7 days can also be given. So this is all about chlamydia conjunctivitis that you should keep in mind. So Question number 31, answer is superior conjunctiva commonly involved. This is a false statement. Now question number 32, what is retinal dialysis? The correct answer to this question is option number A, retinal tear. So let's discuss retinal dialysis briefly. What is retinal tear? Correct answer is, this is question number 32. Question number 32. Question number 32. Answer is retinal tear. So retinal tear is, what is retinal tear? Retinal tear is separation of the retina. Retinal tear is separation from the ora serrata. So there is separation from ora serrata. Now what you should keep in mind is about the ora serrata is that ora serrata is the anterior termination of retina, right? Ora serrata is anterior termination of retina, right? And the most common cause of retinal tear is, usually it is caused by trauma, but it can also occur spontaneously. Retinal tears can also occur spontaneously and they may progress to retinal detachment. So retinal tear may also progress to retinal detachment, right? Now if retinal detachment occurs, the patient will have same clinical features or the same symptoms as of retinal detachment. Patient will complain of photopsia, flashes of light, and the patient will also have complaints of floaters. What are floaters? Floaters are multiple black dot-like opacities seen in front of eyes. Now, so to know further about retinal tear, you should keep in mind about the pathogenesis of rhegmatogenous RD. So what happens that due to syneresis, what is syneresis? Syneresis is liquefaction of vitreous which occurs due to aging. So syneresis is liquefaction. So syneresis of or the liquefaction of vitreous occurs due to aging. Now because of this liquefaction, what happens that there develops a situation which is known as PVD. This is important and you should keep in mind what is PVD is peripheral vitreous detachment. Peripheral vitreous detachment is PVD. So what is the PVD? So there is detachment of the retina or there is detachment of the vitreous, not retina, that is detachment of the vitreous from the retina. Which layer of retina? From the internal limiting membrane of retina. So PVD is detachment of vitreous from internal limiting membrane of retina, right? So because of syneresis, there develops PVD, peripheral vitreous detachment. Vitreous is detached. Now what happens that the remaining vitreous which is attached to the retina, it will exerts a dynamic vitreoretinal traction. Traction means the vitreous is pulling the retina, right? This is dynamic vitreoretinal traction. So PVD will lead to dynamic vitreoretinal traction, right? Now because of this traction, the vitreous is pulling the retina, the attached vitreous is pulling the retina. This condition is dynamic vitreoretinal traction. This can lead to formation of retinal tear or retinal hole can develop. The most preferred location of retinal tear is in inferotemporal quadrant. So what happens because of retinal tear has occurred? Now the vitreous has become liquefied. As we discussed, there is syneresis, means liquefaction of vitreous has occurred. The liquefied vitreous will seep inside the retina because of retinal tear, right? So by seeping inside the retina means that the liquefied vitreous enters into the subretinal space. So retinal tear will lead to collection of liquefied vitreous in subretinal space, right? So vitreous will seep inside the subretinal space, and this condition can lead to retinal detachment, right? So retinal detachment, what is retinal detachment? You should know. It is the separation of the neurosensory retina from the retinal pigment epithelium, and which will lead to collection of fluid in the subretinal space. And retinal hole, this situation occurs because of atrophic neurosensory retina. This can also lead to retinal detachment. So this is all about retinal tear that you should keep in mind. Now coming to next question, question number 33. So again this is an image based question. Hallmark of the clinical condition in the given picture is, answer here is corneal hypoesthesia, option number B, right? Option number B. So as you can see in this image, this is a blue colored cornea, means they have stained it with fluorescent dye, and you are examining the cornea in the red filter, right? And the lesion is looking green in color. This lesion is known as true dendrites, right? True dendrites. This is a typical picture seen in herpes simplex virus dendritic ulcer, right? Herpes simplex virus keratitis. So let's discuss option number A. They have given radial perineuritis. Radial perineuritis is seen in radial perineuritis. This is a clinical feature. This is seen in acanthamoeba keratitis, right? Now option number B is the answer, corneal hypoesthesia, right? Means the corneal sensations have decreased. So let's discuss herpes simplex keratitis. Herpes simplex virus keratitis. So we can see dendritic ulcers here. Dendritic ulcers. So in this image you can appreciate dendritic ulcers which are a linear branching pattern. These ulcers have a linear branching pattern with terminal knobs or buds. With terminal knob or terminal buds, right? Now how the ulcer will look like? Now suppose this is cornea. The buds will look like this, right? So they will have terminal knobs or buds. So how you examine? You examine the dendritic ulcer with the help of fluorescent staining, right? True dendrites. What is the treatment option? We give 3% acyclovir eye ointment 5 times a day, and Debridement can also be done. Debridement of the lesion can also be done. What should not be done is topical steroids. Topical steroids are contraindicated in herpes simplex virus keratitis, right? So now let us discuss the other causes. What are the other causes of decreased corneal sensations? So in herpes simplex virus keratitis, if they ask you the hallmark sign is decreased corneal sensations. Now how you check the corneal sensations? You check the sensations with the help of esthesiometer or with the help of cotton wisp. Cotton wisp can also be used for checking the corneal sensations, right? Now, what else you should know in this question about the nerve supply of cornea? What is the nerve supply of cornea? Remember the mnemonic TON, where T stands for trigeminal nerve. T stands for trigeminal nerve, giving branch to ophthalmic nerve, which further gives branch to nasociliary nerve. So this is the nerve supply. Important thing is, in this question you should keep in mind about the causes of reduced or decreased corneal sensations. So to remember the causes, just keep in mind one mnemonic, that is HDL ACTS. HDL ACTS, where H stands for herpetic virus, herpetic simplex virus keratitis. D stands for diabetes, L for leprosy, A for acoustic neuroma. A stands for acoustic neuroma, C stands for contact lens wearer, T stands for overuse of topical medications like NSAIDs and beta blockers. Overuse of topical NSAIDs and beta blockers. And S stands for surgical trauma. So in this question, these are the causes of decreased corneal sensations that you should also keep in mind, right? So C option they have given is immobile hypopyon, which is seen in fungal keratitis, right? True dendrites are seen in herpes simplex virus keratitis, whereas pseudodendrites is also a condition. Pseudodendrites are nothing but they have the lesions, the dendrites, which do not have terminal knobs or buds. They are pseudodendrites, and they are seen in herpes zoster ophthalmicus and acanthamoeba keratitis. Now coming to question number 34. Question number 34 is, indirect ophthalmoscopy is ideal investigation for all except. Option number A is ora serrata. Yes, it is correct. Base of vitreous, yes, this is also correct. Option number C they have given is fovea centralis. So correct answer is option number C. This indirect ophthalmoscopy is not the ideal investigation for fovea centralis, right? So let us discuss briefly about indirect ophthalmoscopy now. Indirect ophthalmoscopy. So this procedure is done for, what is the use? What is the use of this procedure? It is done for fundus examination. Fundus examination or examination of the posterior segment. Posterior segment. Now one should know what is fundus examination. Fundus examination, this comprises, it comprises the view of transparent vitreous. It comprises the view of transparent vitreous, transparent retina and choroid. Transparent vitreous, transparent retina and choroid. Remember, the red reflex of the eye is due to choroid. So this is fundus view, right? Now, what are the features of indirect ophthalmoscopy? It forms, which type of image is formed? It forms a real and inverted image, right? Real and inverted image is formed on indirect ophthalmoscopy, and a +20 diopter convex lens, convex condensing lens is required for examination of the patient using indirect ophthalmoscopy, right? What are the advantages over the direct ophthalmoscopy of indirect? It has an advantage of stereopsis. Stereopsis is nothing but it is binocular depth perception. Binocular depth perception. The examining doctor will have depth perception in indirect ophthalmoscopy, which is absent in direct ophthalmoscopy, right? Now fundus can be examined in hazy media. Examination can be done in hazy media. Hazy media, what we mean by hazy media, that there can be presence of a corneal opacity or there can be a cataract. Right? Now, area visualized. What area we see by indirect ophthalmoscopy? Right? So, area visualized is periphery of the fundus. Periphery of fundus can be visualized. This is the advantage of indirect ophthalmoscopy over the direct ophthalmoscope. So, periphery of the fundus up to ora serrata, right? So as we already discussed, ora serrata is the anterior termination of the retina, or it is also the junction of ciliary body and choroid, right? So periphery of the fundus up to ora serrata can be visualized with the help of indirect ophthalmoscopy, and fundus anterior to equator can also be visualized, right? So these are the area visualization, which the areas which we can see. Now the area of field is around 45 degrees with +20 diopter lens, right? 45 degrees with +20 diopter lens can be seen with indirect, which is larger than direct ophthalmoscopy, right? In direct ophthalmoscopy, the area of field is around 10 degrees, right? And the field of view if we discuss the field of view is around 8 disc diameters. This is also larger, 8 disc diameters, as compared to direct ophthalmoscopy, in which it is 2 disc diameters. So this is all about indirect ophthalmoscopy that you should keep in mind, right? So the correct option, question number 34, is option number C, fovea centralis. So which is the preferred investigation for visualization of fovea centralis? You can betterly visualize in a better fashion. Fovea centralis can be seen by plus 90 diopter lens using slit lamp biomicroscopy, right? So 90 diopter lens is better than indirect ophthalmoscopy for visualization of fovea centralis, whereas in indirect ophthalmoscopy it is preferred investigation for your examination of peripheral part of the fundus up to ora serrata. So this is all about the ophthalmology questions. Thank you. Best of luck.